In the previous topic, we looked at utilitarianism as a normative framework of public policy. And we saw that utilitarianism was forward-looking as a construct. It was consequentialist. It defined the good in terms of pleasure. It looked to maximise net happiness in a society. It was impartialist. Everyone counted for one and no one for more than one. It drew upon an idea of interpersonally comparable utility, that you could compare the utility that the rich got from their income with the utility that the poor got from their income, for example. And the classical utilitarians at least thought that it was applicable at both the individual and the collective level. In this topic, we're going to look at an application of utilitarianism to an area of public policy, namely priority setting in health policy. And I've chosen this not simply because it's a particular interest of mine. I've been looking at questions of priority setting in health policy for longer than I care to remember, but also because I think this illustrates what it might mean to apply a normative framework like utilitarianism to public policy in practice. And that will enable us to see both the strengths and the weaknesses of utilitarianism when thinking about normative frameworks for public policy. And in particular, the decision paradigm that we're going to be looking at and examining this week, we shall see similar to utilitarianism. It's forward-looking and consequentialist. It's impartialist. It uses an idea of interpersonally comparable utility, and is taken to be applicable at the collective level. There are very interesting questions as to whether you could apply this framework at the interpersonal level, which we don't have time to go in for. Naturally, it's not going to define the good in terms of pleasure, given that it's a health policy. It's going to be defining the good in terms of health status. And we'll see in a subsequent lecture talk precisely how that might be done. But I hope you can see that the framework that we're going to be looking at has the core features of utilitarianism as a way of thinking about policy choice. In this lecture talk, I'm going to talk about the basic elements of health policy, and then I'm going to talk about the role of NICE, the National Institute for Health and Care Excellence, which we will see is the body in England and Wales that has the responsibility for applying this particular decision framework. So, okay, let's look at health policy. And here, obviously, going to have to talk at a very general level, but nonetheless, I think we can define what I would regard as the consensus goals of various health systems. These are the sorts of goals, for example, that you would see supported by the World Health Organization and that you find exemplified in well-functioning health systems around the world. And I think there are three consensus goals. One is that there be no financial barriers to access. And that's important because medical care, particularly medical care to deal with medical emergencies and serious illnesses, can be very expensive to the point at which it's catastrophically financially burdensome. So ensuring that there are no financial barriers to access is a very important principle and very important goal of healthcare policy, that people are not denied access to care on grounds of money. Now, there are very important policy discussions if we go back to our Sabatier framework and think about normative core, policy core, and then the more peripheral aspects. One of the things that one would discuss under the peripheral aspects is what counts as a relevant cost. Clearly, things like medical fees are going to count as a medical cost, but do secondary costs like travel costs to secure medical care, do they count as relevant costs, which we want to prevent people having to incur at least at an exorbitant or unreasonable level. So one consensus goal is no financial barriers to access. A second is that the care be high quality. You can supply care to everybody. For example, many countries have systems which notionally provide care to everybody free of charge, but the quality of care is very poor. It's very rudimentary. Much of the relevant technology cannot be afforded. It's very difficult to pay for the right quality of staff and so on. So we want the care to be clinically right, to be the thing that the best doctors would prescribe for the condition. And we also want things that are associated with good clinical care, like short waiting times and responsiveness to individual circumstance. And finally, we want the care to be comprehensive. So we want the care, for example, not just to cover core medical interventions, but things like dentistry and social care. If you had a healthcare system which was high quality with no financial barriers to access, which covered everything but dentistry, you might say that was a good healthcare system, but it fell short on the test of comprehensiveness. And I'm taking these as three consensus goals. I don't mean to any extent to suggest that those are the only goals of public policy in healthcare, but if you cannot achieve those three, your health system is not doing very well, I think. Okay, so how do you achieve those goals? Well, let's just set up a simple model. Let's just imagine that we have a population of potential patients, and we have providers, doctors, hospitals, nurses, and so on, and the population needs services, and the providers provide the service. Now, obviously there are going to be costs to that provision, and given that some medical interventions can be extremely costly, then that is potentially financially catastrophic for populations. So the real trick of modern healthcare systems, I think probably the most important feature of them, is that they introduce a third-party payer. This could be a health insurance company, it could be a sickness fund, it could be government payment through taxation, could be some combination of these. But the crucial trick is to have a third-party payer to whom the population, through taxes or insurance premiums, what we might think of as shared savings, make a contribution. Just like as with any other insurance, insure your house against fire or your car against the costs of a crash and so on. You make a contribution, you pay into the scheme. And the payer then finances the services to the provider. So we might say that this introduction of the third-party payer addresses the no financial barriers to access question, and in financing the services, the payers, if their public policy is sensible, are going to try to ensure that what they're providing is comprehensive and of good quality. You wouldn't want to pay for services that were of poor quality. We can think about this three-way relationship as a sort of social contract between the population, between the institutions that are paying, whether those state institutions or state-mandated institutions like social insurance funds, and the providers. And these groups contract with one another in order to be able to secure a well-functioning healthcare system. Just to give you some figures, I won't go into these, but this is some data going back over a nearly 30-year period. I haven't taken in the latest data because obviously COVID changes everything in a way. These trends are going to shift. But you can see that these are for 10 high-income countries, and the general trend of expenditure is up across all high-income countries, although there is some variation. The most notable variation is the dramatic increase in costs as a percentage of national income in the United States. In the United States, you can see here that healthcare expenditure, public, private, collective, and so on, is taking about 17% of national income. If you think about that, that means that somebody's got to work, those are in employment providing the income, have got to be working a day a week just basically to cover healthcare expenses. So we're talking about something that is large and growing. I won't go into details about this. You can look at the PDF, but just this is a similar chart, but which breaks down the sources of spending on healthcare between out-of-pocket spending, that's the money that patients have to pay if they go and see a doctor that's not covered by some form of insurance, private spending, which is the money that they may well pay, supplementary to the system of shared savings, and public spending. And you can see that across most countries, again the United States stands out as an exception, across most countries that the trick has been to substitute a high proportion of public spending for what would otherwise be out-of-pocket spending or private spending. So these would cover things like charges for prescriptions, this would cover private hospital operations, for example, and this would cover all the rest in terms of medical care. Now, against that background, with rising costs, potentially catastrophic financial expenditures and so on, The policy problem is how collectively both to determine overall spending and priorities within spending. And the assumption behind this problem is that we could potentially always spend more with some health benefit. We could pay for more research, for example, to extend life or to improve quality of care, or whatever else we want. And at this point, we have the idea enters of health technology assessment, where a health technology is simply some medical or public health intervention that is intended to improve healthcare status. So let's just think about drug development, which obviously has been on our minds in COVID circumstances in recent years. We can think about the pharmaceutical companies as developing drugs. Those drugs have to be tested for what's called market authorization. That is to say, is the drug safe? Is it efficacious? Is it effective? And so on, as the manufacturers claim. And then that potentially goes on to national availability if we're talking about a comprehensive scheme. Health technology assessment comes in between market authorization and national availability and asks the question, given that this drug has been developed, given that this drug seems to be safe and effective, is it worth the cost that the manufacturers would charge the healthcare system in order to make it nationally available? So it provides guidance to payers on whether to reimburse a medicine or medical technology. Now, some countries don't have formal HTA processes, and indeed there's a very interesting discussion about the advantages and disadvantages of HTA processes. But I hope you can see against that background of costs and priorities that the question at least must arise as to whether an intervention, for example, a pharmaceutical product, is worth paying for or not, making it nationally available. And going back to our three-group picture, HTA comes in at this point. It comes in where the payers have to decide whether, in reimbursing the providers, the technology that the providers are offering, in this case the pharmaceutical companies, really is worth paying for. And you can think about HTA as a technique for determining priorities. Quite often, as we shall see, these are difficult decisions, so that you can also think about it as an instrument to aid decision makers in the process of making those difficult decisions. Many people claim that it's an instrument of evidence-based policy making, and this is obviously going to be particularly important in a context in which we're thinking about public policy as a process of public practical reasoning. If it's genuine reasoning, you would want it to be evidence-based. And then it's also sometimes thought of as a tool to increase efficiency, possibly to save money, by assessing which technologies provide best value. And it's in that, I think hope you can see in that last bullet point, that we're already beginning to move into the territory of utilitarianism. And that's going to bring us to the public institution that in England and Wales is responsible for implementing and thinking about all of that, the National Institute for Health and Care Excellence. So let me just talk a little bit about NICE as the last part of this lecture talk. It's called the National Institute for Health and Care Excellence. If you think, why NICE? Because where is the H in NICE? Originally, NICE started off as the National Institute for Clinical Excellence, and it acquired various responsibilities over time, as we'll soon see. It was established in 1998, principally with the intention, the policy goal of ending the so-called postcode lottery. This was a situation in which some healthcare authorities were providing, in particular, drugs and pharmaceutical interventions, particularly the expensive cancer drugs, in some areas of the country and not in others. And it was thought that if you lived, for example, north of a river, which defined an administrative boundary, you should be getting the same care as somebody who lived south of a river in a different administrative boundary, and often that seemed not to be the case, and this led to what is sometimes called a postcode lottery. And it produces these technology appraisals. It conducts healthcare technology, and in particular the technology appraisals are evaluations of pharmaceutical products. And when NICE evaluates a pharmaceutical product, it takes the form of recommended, or not recommended, or only in research. But the crucial point to bear in mind at this stage is that if NICE recommends a pharmaceutical intervention, then the National Health Service is obliged to provide that. If NICE does not recommend an intervention, it doesn't mean to say that the National Health Service will not provide it, but it's got to come out of a discretionary budget. So the crucial distinction is that if NICE recommends, the NHS authorities have no discretion. If it does not recommend, or it recommends against technology, then there is some discretion, although in fact given shortages of funds, that discretion is rarely used. I said I'd say a little bit about NICE. When it started out in 1999, first few years, it was really focusing on these technology appraisals, drugs and so on. It acquired various functions over time, including clinical guidelines, how best to treat patients, intervention procedures like surgery, public health came along, so-called quality standards then came along. I always think you can tell a lot about where an organisation's standing is in government if it acquires functions over time. I think what this chart shows, as NICE acquired more functions, it was regarded as being a successful agency. It had a firm place in the political establishment. And if we think about the decision processes that go on in making a technology appraisal, we obviously have to decide which technologies to appraise. We have to define and scope what we're appraising, what we're looking at. We have to assess their effectiveness. We have to produce an appraisal, and we have to produce a final review. Those are basically the 5 stages. And what we'll be looking at here is the extent to which the assessment of the effects of the drug, right, really lead to a positive appraisal recommended on the one hand, or a negative appraisal not recommended on the other, or this third category of only in research. This point of the decision paradigm is where our utilitarian type arguments are going to come in. NICE is not and has not been uncontroversial. This is a selection of newspaper reports from the early days of NICE, and one of the things that NICE does is it sometimes says that certain drugs are not to be recommended, and it's easy enough to see why, if a drug seems to have health benefits but is judged by NICE to be too expensive for the NHS to purchase, why there might be protests against that. Now, the simple fact of protests is not in itself, I think, decisive. Getting bad coverage in the Daily Mail doesn't show you that your practical public reasoning is amiss. But on the other hand, we want to make sure that if we are in a situation in which a body like NICE, a public agency, is making controversial decisions, we want to make sure that the decision paradigm on which its decisions based are as robust as possible. And to assess that, we're going to go on in the next lecture to look in some detail at the NICE decision process.